بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم أجمعين. اللهم انفعني بما علمتني وعلمني بما ينفعني وزدني علما إنك أنت العليم الحكيم. My topic today is about the peripheral distribution of air space shadowing, reversed bat wing appearance. The common causes, less common causes and rare causes, and the clues for the differential diagnosis. Key differential diagnostic issues. It spares the perihilar regions initially described on chest X-ray, and CT is more sensitive for detection of peripheral consolidation. Clinical history is essential for giving the diagnosis. Common causes: contusion. Contusion, it is interstitial and alveolar hemorrhage due to blunt thoracic injury. Occurs adjacent to the chest wall trauma. Contact contusion can occur but rare, not confined by fissure or segmental anatomical distribution, and usually resolved within a few days. Persistent obesities beyond a few days suggest alternate diagnoses such as sober-imposed infection or aspiration. Here we have chest X-ray with bilateral airspace consolidation with air bronchogram sparing the central areas due to patient with the trauma and due to contusion. This is another patient. We have surgical emphysema and contusion in the lung periphery here, and another contusion in that area with lung laceration. And we have also a right-sided pneumothorax. Less common causes, we have eosinophilic lung disease, cryptogenic organizing pneumonia, pulmonary infarction, acute respiratory distress syndrome, irradiation pneumonitis. The clues for less common diagnosis: eosinophilic lung disease, there is accumulation of eosinophil within the distal airways and interstitium. Several forms of the disease exist. Loeffler syndrome is the most common form. It is present as peripheral obesities are typical finding with these forms. Loeffler syndrome, it is idiopathic peripheral consolidation that clears within 1 month. It is a fleeting airspace shadowing, and it is known as simple eosinophilic pneumonia. A chronic eosinophilic pneumonia, there is peripheral consolidation associated with severe respiratory symptoms lasting at least 3 months, and it is often with upper lobe predominance. Church-Strauss syndrome, it is involved the middle-aged patient with allergy. Lung disease resembles simple or chronic eosinophilic lung disease. Peripheral obesities are less common associated with these forms: acute eosinophilic pneumonia, acute respiratory failure with rapid response to steroid. Appearance resemble more typically pulmonary edema. Eosinophilic syndrome, multi-organ infiltration of eosinophils, and usually present with bilateral pulmonary lung nodules. Here we see patient with chest X-ray with bilateral peripheral consolidation of both lower lobes, little bit more to the left side, with history of shortness of breath in patient with eosinophilic pneumonia. Here, this is non-contrast CT scan patient with bilateral peripheral ground glass opacities and consolidation, as we see here, and sparing the central part. And then this is typical patient with chronic eosinophilic pneumonia. Patient also has peripheral blood eosinophilia. Here, axial contrast enhanced CT scan patient with the peripheral bands of area of consolidation and ground glass opacities in patient with chronic eosinophilic pneumonia. Blood eosinophilia, respiratory symptoms, resolution with corticosteroid therapy. Here, another patient with axial high-resolution CT scan showing subpleural consolidation due to vasculitis in patient with Churg-Strauss disease. The patient has asthma, and common this it is coexisting condition. A cryptogenic organizing pneumonia, before it is called known as idiopathic bronchiolitis obliterans organizing pneumonia, and the term is abandoned now. There is accumulation of foamy macrophages and fibrosis in distal airways. Restrictive lung disease with chronic cough, shortness of breath, low-grade fever. There is patchy area of airspace consolidation or ground glass opacities. Airspace disease is often in the peripheral distribution. Tend to be peribronchiovascular in distribution and can be unilateral or bilateral, more common in the lower lungs. Other CT findings include peribronchial centrilobular nodule, atoll sign or reverse halo sign. There is a concentric opacity with central ground glass opacity. The periphery of that or central glass opacity is consolidation. And they said it is to be characteristic for this disease. Here we see axial non-contrast enhanced CT scan, bilateral airspace consolidation involving both lungs, more to the lung bases and posteriorly, and with a bronchogram with some atoll sign. And this is a cryptogenic organizing pneumonia. Here another patient with axial high-resolution CT scan with peripheral consolidation in the right upper lobe posterior segment with peribronchial consolidation with cryptogenic organizing pneumonia. Pulmonary infarction, usually due to pulmonary artery emboli, also associated with central bronchogenic pneumonia, more common in patients with poor cardiopulmonary reserve, impaired bronchial circulation. Subpleural pulmonary parenchymal consolidation, often wedge-shaped, Hampton hump wedge-shaped peripheral opacity with medial border oriented toward the hilum, central bubbly lucences within peripheral consolidation is suggestive of diagnosis. Here, patient with axial contrast enhanced CT scan, there is a filling defect in the left lower lobe pulmonary artery consistent with pulmonary embolus. And this is the same patient. After 14 days, there is worsening of the chest pain, and we have a revealed peripheral wedge-shaped area of consolidation distal to the pulmonary embolus, and this is typical of pulmonary infarction. Acute respiratory distress syndrome, there is damage to the capillaries that allows for loss of fluid in the lung interstitium and alveolar spaces. Numerous causes: trauma, infection, toxin exposure, emboli, disseminated intravascular DIC, drugs, pancreatitis, and idiopathic adult respiratory distress. Acute respiratory distress syndrome is known also as acute interstitial pneumonia. Often follows a predictable time course. First, 12 to 24 hours normal radiograph appearance, several days later bilateral scattered area of consolidation begins in the periphery and then become confluent. Weeks After weeks, there is a slow resolution of lung consolidation. Months may progress to lung fibrosis and often with anterior predominance. Here, patient with chest X-ray with bilateral uh, peripheral airspace consolidation in patient with acute respiratory distress syndrome. And this is sometimes difficult to differentiate from cardiogenic pulmonary edema. But in cardiogenic pulmonary edema, the central part it is involved. Here, it is not involved. Radiation pneumonitis, occurs 1 to 3 months after radiation therapy and occurs in approximately 40% of patients, associated with diffuse alveolar damage within the irradiating tissue, ground glass opacities, and consolidation with lung tissue corresponding to the location of radiation port. Does not respect fissural and segmental boundaries, often asymptomatic, may resolve or progress to radiation fibrosis. Persistence more than 9 months post-radiation suggests of presence of radiation fibrosis. Here we see axial contrast enhanced CT scan patient. There is airspace shadowing in the peripheral left upper lobe, and it is due to radiation fibrosis, and it is seen in the following next few months. Rare but important causes, we have collagen, vascular disease, and fat embolism. Collagen vascular disease, it is a heterogeneous group of disease including systemic lupus erythematosus, dermatomyositis, polymyositis, scleroderma, and rheumatoid arthritis. Interstitial lung disease is most common pulmonary complication and may see peripheral ground glass opacities and reticulation. We see here in contrast CT scan patient, peripheral area of consolidation, ground glass opacities in patient with dermatomyositis. Fat embolism, usually caused by trauma to the long bones or pelvis. Fat droplets are deposited within smaller vascular spaces. Symptoms developed 1 to 3 days after the blunt trauma. Radiologically, it is not specific, but may reveal acute respiratory distress syndrome pattern, often with peripheral consolidation. Radiography may be normal initially. Diagnosis is clinical: respiratory symptoms and neurological changes due to cerebral disease, hematological changes such as anemia, petechial rash. Here we see chest X-ray shows typical findings of bilateral airspace consolidation and peripheral distribution with geographic area of centrally spared and in patient with fat embolism syndrome. And it is followed trauma to the long bones in the pelvis. And diagnosis is clinical. Thank you very much for listening, and hoping to see you in another topic soon.